This is a case of acute tubular necrosis and renal failure following outpatient antibiotic therapy in a patient with myelodysplastic syndrome. This case teaches us that antibiotics can have untoward and unintended consequences, including acute renal injury. This is an 84-year-old man with a past medical history of myelodysplastic syndrome, hypertension, and prostate cancer. 30 days before his admission, he had a lateral cyst drain from his left knee that was complicated by a localized cellulitis that was treated with Bactrim for 3 weeks. There was reportedly no improvement, and his wound cultures grew Streptococcus galolyticus. His antibiotic course was therefore changed to amoxicillin clavulinate or Augmentin for 10 additional days. He finished the Augmentin 1 day before coming to the hospital. At admission, he presented to the emergency department with diffuse upper and lower extremity anasarca, fatigue, and evidence of acute onset renal failure. During this patient's hospitalization, his urine output progressively decreased despite high doses of IV diuretics. His chemistry panel was notable for worsened hyponatremia and GFR and for persistent hyperkalemia. Kidney biopsy showed acute tubular necrosis. An example of this can be seen in Figure 1. And electron microscopy of his biopsy showed severe podocyte effacement, shown here in Figure 2. Ultimately, he required inpatient, then outpatient hemodialysis for an extended period of time and treatment with steroids for presumed minimal change disease. Review of this case and the literature brings about several important points. The first is that acute tubular necrosis and minimal change disease from antibiotic therapy are, fortunately, relatively rare. Myelodysplastic syndrome has been noted in patients with nephrotic syndrome, so it's possible that there is some overlap in this patient's presentation. Second, acute tubular necrosis is more commonly associated with tetracyclines and cephalosporins. However, amoxicillin, which was used in this case, has been reported to cause acute renal failure. And finally, progressive recovery is common in patients with minimal change disease that is appropriately treated, with remission within 2 to 4 months of steroid therapy in approximately 75 to 90% of patients. We're happy to report that this patient, who is now over 2 months out from this hospitalization, is doing quite well with significantly improved renal function. The take-home points from this patient's experience are that even commonly used antibiotics can cause adverse events, including renal failure. Therefore, physicians should use caution when diagnosing and treating any presumed infection with antibiotics. Clindamycin or Bactrim would have been sufficient, more than likely, in this patient's case, thereby avoiding the untoward renal failure that Augmentin may have caused.